Derrek. Hi, and thank you so much for joining me on Faces of Digital Health. You're an oncologist, a clinician, and somebody that's very, very passionate about technology and the adoption of technology, and is also very vocal about this on LinkedIn. You bring a lot of clarity about the introduction of innovation into healthcare to the audience that you've managed to build. So I'm glad to have you here to talk a little bit about what it means to be a clinician in the era of AI, when key AI leaders are entering healthcare. The position of clinicians in healthcare is changing. NHS, as always, is under pressure. And I want to dive into some of the healthcare trends with you as well. So welcome.
Well, it's lovely to be here, Tjasa. We've been a big fan of the podcast and we've listened to quite a lot of episodes so far. So it's great to be here. And yeah, I'm hoping to have an honest and an open conversation about the work that we have done, but also the trends that you are seeing as well.
Wonderful. If we start on the provocative end, at the World Economic Forum, Elon Musk said that it doesn't make sense to study medicine anymore. Obviously, it's a provocative statement, but I do wonder, what do you think about it?
Well, I think we should probably start off with the fact that, I'm pretty sure when Elon is sick, or if someone who he loves is sick, he'll probably still call for a doctor. And that will probably be the case even in 10, 20 years' time, because I'm pretty sure he will not be relying on Grok or an AI to be looking after someone who's really, really sick or unwell. Maybe for some simple cough and colds, maybe. But when someone's properly sick with, cancer or with like a serious heart attack, it's probably humans and doctors that you actually need to see. But I don't want to come across as someone who denies the inevitable progress that AI is making in healthcare. And the truth of the matter is, I'm sure that statement is really just a provocative statement, to just grab headlines to get us talking about it like we are doing it right now. But really, I think AI is evolving at an incredible rate, and this year we've seen the emergence of, ChatGPT Health, Cloud Health, Gemini Health, and everyone's coming into this space so fast that regulators are busy trying to catch up. I think AI can do a lot of things well, it can certainly gather information a lot faster. It can analyze and interpret a large amount of data very quickly. And with that, it allows them to do pattern recognition probably much faster than an average clinician could, Perhaps the most excellent doctors will probably still outperform AI in many domains. But there are certain things that we cannot deny that AI is much better at us at. It's probably better at looking through 100 papers to analyze the current state of evidence of the current treatment. And, that's why we see like open evidence, they've reached a $4 billion valuation simply because it does one thing that we can't do very well, which is keep up with research as well. So I see AI really fulfilling quite a good role. And AI is also quite good at taking very complex subject matters and turning it quite simple. So, I'm a cancer doctor, so I work in the Beatson Cancer Center in Glasgow, and I've actually seen many, many times patients bringing me like a sheet of paper that they've printed out from ChatGPT, and, essentially ChatGPT explain what was going on and what they were doing. And I would say it's about often 80% correct, especially if they've inputted the correct data and the correct understanding of what their current disease process is and how their current clinical situation is. ChatGPT can really explain things in quite a simple way for the layperson to understand. So we mustn't throw the baby out with the bathwater and say that, AI doesn't have a role in healthcare or AI is going to replace doctors, but rather understand that it is a technology that can bring a lot of good for a lot of people. And it's often we work in tandem with. Is there a purpose to study medicine from now onwards? Elon Musk also famously said that radiologists, Elon Musk also famously said that driverless cars will be here by this time in 5 years ago. So, and another person has also mentioned that radiologists will be replaced by 2026. And right now, radiologists are still driving their cars to work. So it's still very much a lot more to be said. But people often overestimate the value of technology in the short term and underestimate the value of technology in the long term. So I think we still have to reserve some judgment about where we will be in the next 10 years.
It's interesting that when you mentioned how patients use AI to simplify the clinical language, a group of hospitals in Belgium actually did a project where they created an open source solution that translates the clinical discharge letters into lay language. So these types of things are definitely happening on a wider scale as well, which is great. I do wonder, to which extent do you see that because of these new tools that enable patients to learn more about their diseases and also the options that they have in terms of treatments, how is this changing the dynamics between patients and clinicians? There's many patient stories or patient advocates that either had a cancer diagnosis that was terminal and then they weren't willing to give up. They dug into the data and they either found a clinical trial for them. When it comes to these stories, I think it's worth emphasizing that these are not the majority of patients. So most of the time in healthcare, we sometimes forget that things still go right. But there are these cases where patients solve their own problem in a way, and knowing that by 2030 we're gonna be missing 10 million doctors and that access is increasingly becoming more challenging. How do you see that patients with their productivity could speed up access to treatments by basically helping doctors as research assistants?
Yeah, essentially. I have two key thoughts about this. So the first, to answer the question, I need to go by another question and to ask, who do you think cares the most about a patient's health? It's the patient themselves. It's ultimately patients themselves who care about their own health the most. And the truth of the matter is, doctors, they look after 100, 200 patients at any given time. Doctors are human beings. They can very easily make mistakes and they can very easily miss something, and while the system, the whole healthcare system is there to try to prevent this near misses from happening, misses do occur. However, a patient just have their own health or the health of their own loved ones to look after. So they're often more on the ball. Rather than talking about AI, I think we need to give patients more access to their own data. We need to empower patients with their own data so that they can be very clear and aware of where they are in their health journey and what they can do. And I think that's very important. Now, previously in the past, there was this whole conversation about, I'm worried that we give patients their data, they don't know what to do about it, and then they'll come back to the clinicians and ask them and increase the workload, which ethically is not the wrong thing. But now with a whole added layer of, ChatGPT health, with Gemini health, with cloud health, and as these solutions get more and more sophisticated and advanced, and eventually will get regulated to become something a bit more robust, or there's a regulated version of it kind of coming out, patients will get a better understanding of where they are in their health journey, and they will know what they can do for themselves, without having necessary to wait for 6 weeks to meet a clinician or consultant. And oftentimes we know, and I know, I've seen this myself, the gap between the 2 weeks or the 3 weeks or the 4 weeks between seeing a doctor and receiving a diagnosis is the worst, because they end up sitting there wondering, worrying, not knowing what to do, not knowing what to say. And that is what kills people most. People are really anxious, people are very concerned about their health. And I think when you empower people with more knowledge and information and the data of their own health, their scan reports, their letters that's coming across, their appointment letters, when we empower them with this information, I believe they can take greater agency of their own health. So definitely, I think we should empower our patients more. And it's not really an AI problem more than it is a data problem. Because yes, ChatGPT Health and Gemini Health and Cloud Health, they can analyze all the data. But as the famous saying go, garbage in, garbage out. If you just feed them like half your clinical letters or blood results that are not right or that's missing, or you get some of blood results here, some blood results there, or you don't get any good data at all, the ChatGPT Health or Gemini Health is not going to be able to do anything for you. So really, we need to fix that layer of enabling our patients to get access to their own data more. And I think that's a big challenge even in developed nations like the UK, US, or the EU, much less developing countries, you know.
Yeah, it's interesting to hear that because at the same time, especially I guess in the European Union, many countries are introducing national portals where you have your healthcare information. The situation isn't ideal because oftentimes these are PDF, but to a large degree you can get to the information. But without going too much into the whole data discussion, I do wonder, you work in the NHS. The news was full of NHS internationally at the beginning of last year when there was a huge restructuring that was announced. So I'm wondering, a year later, do you feel that anything is different, or do things still feel the same?
So, just it's very interesting that you mentioned this because just today they've come out a timeline. For our readers who are not aware, the government essentially wants to abolish NHS England as a body and just push all of it into the Department of Health and Social Care, so the DHSC, and essentially it will be now the DHSC that looks after the NHS, and NHS England as an entity and as a body is removed. And really, this move is made because they feel like there's no point having a middle person. They just increase bureaucracy, increase management, and it causes a lot of money. So they wanted to abolish that. But the truth of the matter is, it's a very slow process, and it is because NHS England is huge. It's very, very big, and we are talking about lots and lots of people. And we know that they will bother lay off something like 15,000 or 16,000 people. And with such a huge organization, this kind of process goes very slowly. So they say this entire merging should be complete by April 2027. All right. The timeline has come out. It should be April 2027 where this whole thing is completed. Right now, have we seen anything practical or anything beneficial from it? No. Because right now, everyone is just scrambling, deciding who to fire, who to keep, who have to voluntarily give up their roles, etc., etc. So it's actually more chaos on the ground, and a lot of people have no idea what's going to happen to their jobs, and the benefits that are proposed have not been seen. It's just really the chaos. So a lot of what we will hopefully see the benefits will probably come around 2027 or maybe at least late 2026. So will this really reduce bureaucracy? Will this really reduce management? Theory and reality, it often is very different. And I think I'm someone who will only believe it when we see it. But I guess for our listeners, keep an eye on the ground. A lot more is going to happen in Q1 2026, and if the government's estimation is to be believed, it will be April 2027 where we see the DHSC completely merging with the NHS England, and we'll have a whole new structure, one that's supposedly more lean and less bureaucratic. But we'll see. We'll see.
Yeah.
Yeah, we'll see.
And change is usually painful and it always takes time. So
Yes.
I would say let's put our patience in out there before being too disappointed. One of the things that I really, really wanted to talk to you about was also the position of clinicians at the moment. So we know that the working conditions are not ideal, generally speaking, in many countries. The strain on healthcare is big. That's why in public systems there's a lot of parallel private practices that are opening up and are kind of disrupting the public organization of healthcare. And it is partially simply also because younger generations have different anticipations around the work-life balance and how their work is supposed to look like compared to maybe some of the older generations that basically sacrifice their life for medicine.
Yeah.
And you wear several hats. You're the co-founder of a consulting group. You work with healthcare companies. How many doctors similar to yourself do you see in your peer group? And basically, how do you see that the workforce is changing, or the expectations of how work should look like and working conditions?
Yeah, I think that's a lot to unpack there, Tjasa. The working conditions are becoming a bit more strained, not because of really anything. It's just a reflection of an increased workload and demand. We've just had a conversation with my consultants not too long ago, and they realized that, wow, the amount of patients that are coming through is more and more, much more significant compared to just 30 years ago. And we're just even looking at the cancer perspective, we are seeing a lot more patients coming through. And it's not just that because more people are having cancer, but it's more that we have more technologies and more treatment. Because we can do more now, we end up doing a lot more. So back then, there wasn't, like, for heart attacks, if someone has a heart attack, you give them some aspirin and you hope for the best, or some blood thinners. Now you can do a cabbage, you can do a stent, you can do so many things for it. And as we are able to do more, we end up suffering from success. We end up suffering from success. People are living longer, and when people are living longer, people get more chronic diseases, people get more cancer, and our healthcare expenditure goes up. But at the same time, our provisions have not grown on equal pace, and it takes quite a long time to train a healthcare professional. That's why we are obviously on the losing side of the battle in terms of supply and demand of workforce. And as you mentioned very rightly earlier on, we are expected to have a 10 million shortfall of doctors, and you don't even want to know the numbers for nurses.
Yeah,
So
yeah.
things are changing, and I think you don't need to see so far than to just look at the fact that strikes are happening in the UK. The strikes have happened in Scotland. We were meant to strike last week, 2 weeks ago, but we managed to come to a historic deal with the government to improve pay conditions, and the strike didn't went on, which is very thankful. But in England, strikes have went on quite a few times now, and the strikes have cost the government $1.2 billion. Just last year, in 2025, that's the most recent data that we found. The government actually had to provide another $1.2 billion to try to stop the strikes, and there are still ongoing strikes going on, and because a formidable deal has not yet been agreed upon. As
What's
of
the
this,
biggest complaint around these strikes?
so there's two biggest complaints. The first complaint is obviously pay. Inflation has hit the UK quite significantly. In October 2022, I think the inflation was 11.1%, which is insane, absolutely insane. And, over the past 4 years, inflation has actually went up about like 28%. But then obviously pay has not went up in that commensurate amount, and the pay erosion is very, very significant. So pay is the biggest striking point. They think the doctors are just really not paid enough for the work that they do, which is true. And the second big point that they're striking for actually comes to do with further training, specialty training. In the UK, because we've removed the resident labour market test, essentially anyone in the whole wide world can apply to specialty training in the UK right now. So they opened the floodgates, and it's caused the competition ratio to go absolutely crazy, where even UK medical graduates who train in the UK are struggling to get jobs. So what's happening now is we're getting a whole wave of UK doctors becoming unemployed. And unemployment becomes a very real deal, because a lot of people assume that doctors usually you will be employed throughout the whole period of your training. But the truth of the matter is, if your first 2 years are guaranteed, essentially your FY1 and FY2 is guaranteed, even there we're starting to see a lot of pressure. Some patients, some medical students couldn't even get FY1, but that is quite rare. But after you finish your FY2 training, you need to apply for specialty training. And in the past 10 years ago, you apply for anything, you get anything, right? Maybe not the most competitive things like neurosurgery or cardiothoracic surgery, but internal medicine training, pediatric training, psychiatric training, general surgery training. These are more reasonable things that you normally can go for. But now the competition ratio has shot up so high because they removed the resident labor market test, which is a test that say that a UK a UK graduate needs to be prioritized first before they open it up to external countries, which is the correct standard for most of the world. Because they've done that, now the competition ratio has just shot up to insane numbers, where it's so high that a current consultant now would struggle to get a job if they apply from scratch, because you need to have like a PhD, you need to have like 10 research papers or something ridiculous like that. So that's another striking point. So that's why there's this UK medical graduate prioritization bill that's coming up in hopes to appease the UK medical graduates. But the pendulum swings left and right all the time. In 2017, before the resident labor market test was abolished, there was very little people applying for specialty training. So the government panicked and they removed the resident labor market test. And then we have too many people. And then here we are again. The pendulum will swing back and forth.
Sounds very dynamic, to put it mildly.
Yeah.
So, but like, if I still have a hard time imagining that employment would be an issue. Is it? Could you just elaborate that a little bit further? So, is it just the usual issue that
Right. So
you can't exactly do the specialty that you would like to because, or
yeah,
where?
yeah, I can explain this a little bit more. It's a bit more nuanced, and you wouldn't understand this unless you're a doctor in the UK yourself. So, okay, how were things like in the good old days? All right. So you would do your foundation year training 1, foundation year training 2. Then you come up and you say, back then people don't have that pressure to specialize so quickly. Most of our consultants, most of our the previous generation, they would say, okay, I'm going to do a few years of clinical fellowship first, where it's not a training position, where it's just a service provision kind of thing. I'll do 1 year in respiratory, I'll do another year in cardiology, and then I'll figure out what I like to do. Then I'll apply for training in that general direction. The problem is because of two things. Number one, the government is getting more and more poor, so funding is getting tighter and tighter. And then there's in many boards, NHS trusts right now, there's a hiring freeze. So they're not allowed to hire anyone. No janitors, no one, absolutely no one. So clinical fellow jobs are shrinking significantly. It's very much harder to get clinical fellow jobs now. The second thing is they are also employing a lot more physician assistants and also associate nurse practitioners to fill up a lot of these roles. And this is a huge topic of debate as well, where they're hiring cheaper staff, less trained staff to do like the ward jobs. But a huge report has actually came out to show that, this approach, yes, you can fill a lot of numbers very quickly, but it's actually a lot more dangerous because these staff tend to be not very well trained, and they actually end up costing more safety issues, and they actually end up costing more money in the end of the day. So the government end up paying more money for less qualified staff, which is very, very silly. And now the third factor is the fact that specialty training has become so difficult to get. So you combine these three factors, and suddenly you'll find a UK medical graduate who's done very well in medical school, passed FY1, FY2, apply for specialty training, didn't got specialty training, try to find for clinical fellow jobs, no clinical fellow jobs, or the clinical fellow job is 300 miles away. Then what? Then they are unemployed. Then that's it. They are unemployed. So that is the reality. If you don't have a job, you're unemployed. And previously, it was never that big a problem because there were lots of clinical fellow jobs, there were training positions available, and people were at least, even though they're not paid super well, at least they're employed. So this is one of the major stimulus for the unhappiness that we're seeing in medical training as well. Which is a bit of it's a bit ironic, isn't it, Tjasa? On one hand, we say that AI, we're talking about AI replacing doctors and etc. But the real problem is we have a desperate need for doctors, but there are unemployed doctors as well, and we have well-trained staff, but they can't find jobs. We need general practitioners, but there are general practitioners who have gone through training, but they can't find jobs. And you start to see this is a very ironic situation, isn't it?
Yeah,
So
yeah.
it's a huge mismatch. Theory and reality often doesn't put into place, and ultimately it's a matter of funding and economy and policy.
Exactly, exactly. Yeah, that's exactly right. Perhaps just to add to that, challenge with the shortages and the workforce, an interesting data point that I came across was a report from OECD. Let me just try to see if I can show that. If anybody is interested in digging a little bit deeper. So it's basically a health at glance report from 2024 that shows that another challenge that you don't often think about is also the aging of the workforce. So on top of
Yep.
population aging, the workforce is aging. And in Europe, 1/3 of clinicians and 1/4 of nurses are older than 55, and the interest for nursing has dropped in more than half of the EU countries from 2018 to 2022. So if anybody wants to see this, it's an OECD report. And you got me thinking when you mentioned the whole situation with unemployment, and you co-founded a medical consulting group that is trying to give tech companies access to clinicians,
Clinicians.
so the solutions are actually useful, not just based on what somebody that's outside of healthcare thinks might be useful for clinicians. And
Yeah.
your organization is not the only one in the UK that kind of encourages doctors to think more broadly, to think outside the medical practice. There's doctorpreneurs, there's medic footprints. How do you differentiate? How is the medical consulting group working
Yeah.
so far? Can you tell me a little bit more about who do you work
Yeah.
with, etc.?
Yes, of course. Thanks for the good question. So there are some amazing organizations in the UK like Medic Footprint, Doctorpreneur, Byte Labs, etc., and we're all friends with them. In fact, we are co-hosting an event with Medic Footprints just this February, in Hill House, for clinicians as well. Often we are very collaborative in this space, and actually, a lot of people think we're competitors, but really we're very, very different in what we do. So the medical consulting group, I founded the medical consulting group together with Thomas about 2.5 years ago. And really what we do is we connect health tech companies with the right healthcare professionals. We have worked with about 57 different health tech startups. Most of them, 47, not 57, 47 different health tech startups. And we have them connected over close to 300 healthcare professionals throughout the UK and across EU and also in the United States as well. And we work with a broad range of startups, and we won't work with pharma, insurance company, startups, and we go from a whole range of women's health to physical medical device, mostly AI, to some biotech solutions as well. A lot of what we do is really helping health tech teams, biotech teams understand how should they build something that would actually work in the healthcare space and people actually need and want, or people can actually buy. How do you build something that fits into the clinical pathway rather than is very good but completely cannot be used at all in the setting that you want it to go? So we bring a lot of this clinical expertise, and the people that we bring in are often very senior clinicians. So we're not talking about junior doctors, but we're more talking about consultant grade doctors that have worked there's a head of department or a key opinion leader in their space, because these are the kind of insights and expertise that our clients require. So we often run workshops, focus groups, one-on-one consultations, and we bring in the right people for the right team. And I think that's the key thing that we do. We take a very hands-on approach. Every single meeting we coordinate ourselves. We make sure that the clinicians have a personalized invite. We tell them this is what the job is going to be about. We sort out things like indemnity, paperwork, funding, payment, all that stuff. So we do everything for our clinicians so that they can just go into that session, deliver that awesome value, and go out. And we often pay them immediately after the session. Often we pay them on the same day, even before our clients pay us, because we feel that you have to make things super easy for the healthcare professional so that they won't be put off working with industry, because working with industry comes with its own risk and people are worried about this. So we try to reduce that barrier as much as we can. And so far that approach has served us very, very well. And that's why we have been growing more and more in terms of our, our footprint and our revenue. But I think that's the whole purpose in the end of the day is about trying to get the right people to collaborate with each other.
Mm-hmm.
And once both parties, I personally believe, Tjasa, that healthcare cannot save itself. If healthcare has the ability to solve all its problems, it would have solved all of it 10 years ago or 5 years ago. But still, we are stuck in this situation because we need all the best innovations that we have seen in our lifetime has come from collaboration with industry. CT scan, MRI scan, a lot of drugs that we see that's available have all come because industry collaborated with clinicians rather than someone just trying to do things on their own. So that's the approach that I believe, and that's why we founded the Medical Consulting Group.
When did you start to be interested in technology and maybe looking into it a little bit more closely? I know that you were engaged with the development of an AI tools focused on empowering physicians with clinical decision making already years ago. So can you talk a little bit more about how did your attention came, to technology and digital health?
Yeah, and this story, I think I told it quite a few times, but essentially, ChatGPT, my son was born in November 2022. ChatGPT came out around that time as well. And, I was remember looking at ChatGPT and I was like, wow, this is such an amazing thing. And then you start to see a lot of AI hype going around in 2023. Everyone's just talking about AI. It was incredible how many people are talking about AI, more so than we are doing now. But we see all of these amazing things on the news, and I go back to my ward and we're using pen and paper, So there's a huge discrepancy between what's out there and what's in reality. So I did a bit more research on why is this case. And at that time, the European Union actually put out a commission paper that said that almost 70 to 80% of AI never makes it past the research phase. Majority of them don't even make it to deployment in real life. And one of the biggest reasons cited in that paper was a lack of stakeholder engagement. So human beings aren't the people who are supposed to use that tool have not been consulted. They just build this in a lab, try it in a research environment, and that's it. Nobody can use it. So I took a selfie on LinkedIn 3 years ago and say, hey, this is a picture of me. My name is Derek. I'm a human being. I'm a human doctor. If you're building AI in the healthcare space, please reach out to me. I'll be happy to have a chat. And that was when I had 0 followers on LinkedIn. And lo and behold, just that one little selfie has reached, there's like 6 startups reach out to me in that 1 month. And then soon it became 6 startups in 1 week. And then some days I had 6 startups reaching out to me in 1 day. And I realized, okay, there's something here that we need to address significantly. And that feedback just keep coming back to me. We are really struggling to speak to the clinicians. We are talking about startups who have raised good funding and they're like, I really need to speak to a lot of clinicians very, very quickly, but I'm really struggling to do so. It's really difficult reaching out to doctors on LinkedIn. Can you help me, please? And after doing lots of consultations with it, I realized, we actually need to turn this into a business because I can't do this for free forever. So we set up a business and we just start delivering the value as we need it. So that's how we actually came across this thing, sheerly because the people and the demand pushed us to do this, and we're just serving a need essentially.
Yeah. I can totally identify with what you mentioned at the beginning, which is this discrepancy between all the innovation that you maybe see on conferences, the web, in the news. You look at the websites of the companies, but then you can't use the solutions either because the company is based in a different country or it's limited to a particular institution. So it's not that ideas aren't there, but access is for sure a big challenge. So knowing what you know and what you observe when you're looking at trends and companies, etc., how would you wish to be able to use tech? What is the gap that you see between what you can use in daily practice versus what you see being developed and would love to use, but for some reason can't?
So I think I can tell you a very good story about how tech should be deployed in healthcare. I run a lung cancer clinic one day. I was doing a lung cancer clinic and I was seeing a lot of patients. And in a lung cancer clinic, one of the typical things that we do is we do a chest x-ray for a patient before they come and see us. So we look at the chest x-ray to make sure everything's okay. It's a fast and easy thing to do. And I remember clicking on my program and the thing loaded up. And suddenly there was two screens. One screen was the chest x-ray and one screen was a chest x-ray with an AI interpretation. And the AI was like, oh, there's a pleural effusion here. Oh, the mass here looks a bit smaller compared to the mass previously in the future. So it just appeared. I didn't have to do an extra click. I didn't have to do anything. It just appeared seamlessly into my field. And I'm like, that's pretty good. Not that I really needed to use that AI tool, but it was something that just appeared. I didn't have to open another program. I didn't have to log in another time and click forget my password. I didn't have to do anything special or new. It just appeared. That is how seamless health tech needs to be. Because a radiologist once made a very famous comment: if this tool needs me to make one extra click, I'm not using it. Because one extra click multiplied 1,000 times through 1,000 patients is a lot of clicks. And if the benefit is marginal, that extra click is not worth my time, So that's the kind of seamless integration that people need. We always wish for it, but it rarely happens that way. But if you can't make it that seamless, then you have to at least make sure that the benefit of it is significant rather than just marginal. So I think that's the wish that we have, that can we do something that's a bit more seamless,
Yeah,
And
the user experience.
the user experience matters so much, but oftentimes the user experience has been completely ignored. I mean, a lot of people, they tend to focus more on safety and more on cybersecurity, which is fair. But by doing so, they completely just forget about the user experience, And it really shows. It really shows when you open up a software and you have to click 1,000 things that doesn't have any relevance at all, and it slows down the program. It shows.
Absolutely. I remember already 3 years ago, I had an interview at one of the large conferences in the US, and the CEO of a company came to me and was like, yeah, we just had a meeting with one of the CFOs of a potential client, and they said that if we can show that we're 10 times better from what they already have, they're not interested, which just goes through exactly what you were saying around the improvements that are needed. To wrap up our discussion, based on everything that we've discussed, especially the challenges around the workforce that you mentioned in the NHS, is there anything that you think policymakers are not paying enough attention to when it comes to thinking about the future of clinical workforce?
I think the problem is we are doing things too much in silos. We are not thinking about the big picture. Let me explain to you why. Okay, so when the government saw that there was going to be a shortage of doctors, they set up a lot of medical schools. They set up more medical schools. They increased medical schools positions, but they didn't increase the foundation training program number. So what happens is you have more graduates, but less foundation training. So all these medical students, which the government, essentially for each medical student that the UK train, the government has to spend about like 100,000, 150,000 pounds per student. And this student at the end of fifth year realizes, oh, there's not enough foundation year program. I have to wait 1 year. All right. And then when you finish your FY2 training, suddenly I said no specialty training programs. And when after you finish specialty trainings, there's not enough consultant jobs for the registrars who finish their training. So it's all about understanding that whole flow and not just pulling a level on one side but not fixing the levels on the other side. It's all simple workforce planning. But of course, each of these programs, the foundation training program, the specialty training program, the consultant spots, they are managed by different people, and that needs to be a more joined up approach. If you're going to increase one, you have to increase the rest as well, or else you're just going to have a bottleneck. You're speeding up one, but you're not fixing the problem. So that is one thing that I would strongly advocate for, to not just increase the bottleneck of one place, because you just cause yourself a big problem and people start to strike because of that.
Yeah, absolutely. And then the public complains that the um, public money
Being wasted.
isn't
Yeah, is
spent well.
properly.
Yeah.
Yeah, exactly. For every for every doctor that leaves the UK to Australia or to Canada, we take a very material loss to the NHS. And retention is a lot more important than creating new doctors. Because the people that you retain, they keep the knowledge, the experience. You don't need to bring them through induction again. They have the tribal knowledge. They know how things work. So if you can retain your staff, it's a lot better than training a new staff.
Mm-hmm.
Hmm.
Definitely a topic that I think we might overlook too often, the whole
Yes.
retention challenge. Derek, thank you so much for your time today and for sharing your insights. Good luck with your projects, and let's keep in touch.
Yes, of course. Lovely to have you here, Tjasa.